waiting for people to assemble. All right. You ready? Everybody ready? Calling the meeting to order. Apologize for starting a few minutes late. Will the secretary please call the roll?
Director Green? Present. Director Harrington?
Present.
Director Lowry?
Present.
Director Robinson?
Present.
Chair Ryder?
Ryder is here.
And also present remotely is Board Chair Garza. You have a quorum.
Present, thank you.
Yep. And we more than exceed quorum, so we need a motion. Anybody? Yeah, he's not a member of the committee. All right. The next regular meeting of the Finance Committee is scheduled for Thursday, February 19th at 10 a.m. Debbie, is there anyone registered to provide in-person or virtual oral testimony?
We didn't receive any registrations nor any written testimony.
Do we have no written testimony either?
Nope.
Okay. Is there any members of the public here who would like to speak but have not previously registered to speak? Does not appear, so I'll ask one more time. Is there any members of the public? Okay. All right. Great. We're now going to move on to action items. First is the December 11th, 2025 Finance Committee meeting minutes. These were approved at the December board meeting, but are now being presented for the committee's review and discussion if necessary. Are there any corrections needed to be made to the minutes? Any corrections? Any corrections? Any corrections? Hearing none. Is there a motion to accept item 3A, the December 11th, 2025 Finance Committee meeting minutes? So moved. Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye. Aye. Opposed? The ayes have it. Items under the Chief Procurement Officer, Charles Jones, has a big list of items for us today. Charles, do you want to first give us our overview before we call the first executive sponsor up?
Yes, sir. Good morning, Chief Procurement Officer, and Happy New Year to those that I have not seen yet. Yes, we have 9 items for you today, and of the 9, all 9 required responsive letters from the Office of Contract Compliance. We have 8 back and 1 in process. With that, thank you.
All right. Requests number 1 and 2 are being presented by Aaron Galiner, Chief Administrative Officer for Health Plan Services. Happy New Year, Aaron. Happy New Year.
Morning, directors. The first request before you is a 1-year extension, total cost $350,000 for vendor Collective Medical Technologies. This vendor provides real-time alerts to us for admissions, discharges, and transfers that's happening across our membership, which then gets fed down to our care management teams to help engage and intervene with members.
Any questions on request number 1? If not, Aaron, go ahead with request number 2.
Item number 2 really reflects sort of the next iteration of our housing strategy to support our members. So this is a new contract as a result of an RFP. The vendor is a Safe Haven. This is really focused on shorter term transitional housing. So this would provide housing for members for as up to potentially 6 months, which gives us the opportunity to stabilize the individual and their housing situation, and in turn stabilize their medical costs, and then hopefully transition them to a more permanent housing situation.
Thank you. Unless there's any other questions for Aaron, we're going to move on to request number 3 and 4.
I have a request, not a question.
Sure.
Because I'm assuming that this is leading to better health outcomes down the line, and that's the plan. And it'd be interesting to see how this has been working. You know, if you could report back on sometime how it's worked, and give some examples of people that actually got housing and now getting the health care that they needed.
Absolutely. This will be a new intervention for the specific program and time frame, but for housing interventions we've done in the past, we certainly have that data, and we're happy to share.
Thanks, Aaron. We're going to move to request number 3 and 4. presented by Dr. Lauren Smith, our Chief Medical Officer. And she is
Good.
presenting remotely.
Yes, good morning, directors.
Good morning.
The first contract is an extended increased contract with Demetra Soder, who is a physician. This is a sole source, as this physician is a retired CCH physician, but specializes in child abuse care. This is for an extension for 24 months to end April 30th, 2028, not to exceed the amount of $260,000. The next contract is an execute contract with BioSense Webster. This is a service agreement to provide software updates. This again is sole source due to the fact that we already have the actual capital equipment. So again, this is just for software upgrades. This is for a 36-month period ending January 31st, 2029, not to exceed the amount of $484,500.
All right, any questions for Dr. Smith? Hearing none, moving on to, thank you, request number 5, communications, Alex Normington, our Chief Communications and Marketing Officer. Alex?
Good morning. Alex Normington, Chief Communications Officer. This contract is the second of the one-year renewals allowed under our existing contract with Res Publica Group, our marketing agency. It was issued through an RFP. The value is $8.2 million, and it supports both the health system and county care with paid marketing campaigns, website hosting and management, social media management, video creation, branding, research, and grant-funded public education campaigns. This is an increase over last year of $700,000 to accommodate a grant that the Core Center received to promote HIV testing and care from the Chicago Department of Public Health. So I think in the transmittal, we need to take out one of those C's to make it CDPH. And the vendor continues to meet or exceed goals set by the Office of Contract Compliance. And that's all from me.
Any questions for Alex? Hearing none, thank you, Alex.
Thank you.
Request number 6, equity and inclusion, being presented by our Chief Equity and Inclusion Officer, Shannon Andrews. Happy New Year.
Good morning and Happy New Year. This item
Good morning.
before you today is a request for a new contract. I think it's with the First Public, but I can, the vendor for this is Lindy Gas and Equipment out of Maywood, Illinois. They provide medical gas supply and tank rental for the organization. This new contract will have a 3-year term with 2 one-year renewal options. The 3-year term not to exceed $3 million. And again, this is for system-wide medical gas supplies and tank rental.
Any questions for Shannon? Hearing none, move on to request number 7, nursing. Elizabeth Baklavich. Baklavich or Baklavich? I know we talked about this last time.
Vaslovic,
Baklavich.
yes.
I had it right last time, didn't I?
Old Bohemian, yes.
I was trying to be cute with my Croatian pronunciation.
I think it could go either way.
Yeah.
I will answer. Thank you. So this board approval request is for GE. It's for a one-time purchase and installation for a total of $17,713,941. This is for the installation of new GE monitors to replace the ones that we have and to provide those system upgrades and technology upgrades that are necessary in both Stroger and Provident hospitals.
All right. Any questions? Hearing none, thank you. We're going to go to request number 8 and 9, being presented by Craig Williams, our Executive Chief Operating Officer.
Good morning.
Good morning.
First one I have is Jones Lang and LaSalle, JLL. It's an extended increased contract for $2,244,000. We're asking for a 9-month contract extension, 11/5/25 to 8/4/26. They currently provide assistants in our facilities management, personnel, so they staff the facility managers at Provident and Stroger, work under Alejandro Corona, who's our chief facilities officer. We just completed our RFP selection process, so we're just in, contracting, so this is just to get us through that contracting process. And that's why it's only a 9-month contract.
Any questions for Craig on this request?
The next one is ValueMed. It's an extended increased contract for $140,000, 12-month contract extension, 2/1/26 through 1/31/27. This is a contract we use to rent ventilators to support the respiratory needs of our patients who can't ventilate, oxygenated protector on the airway. We own and lease some of these, and this allows us flexibility based on patient needs and volume.
All right. Any questions for Craig on this item? Thank you, Craig. Thank you. See you in a little bit. Next, we're gonna, Charles, do you have anything else on these items?
No, sir.
Then I would ask for a motion to approve item 4A, contract procurement items containing request number 1 through 9, subject to completion of review by contract compliance.
So moved.
Motion's been made. Is there a second? Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? Let's have it. Charles, we'll now go to your MBE WBE report.
All right. Thank you very much. So before you, you have the third quarter of 2025 for the months of June, July, and August of 2025. Looking second column to the left, there was 14 items brought before you in June. Of the 14, 3 had contract-specific goals for $16.67 million. Unfortunately, there was no prime awards for those 3. 2 of those did have subcontracting for $7.75 million and approximately 47% of the total. Unfortunately, there was also one waiver for $200,000. We had a contract for health information services for project management that a waiver was issued for. Moving to July. In July, there was 22 contracts presented with 14 that had contract-specific goals of $116.3 million. 3 primes were awarded for $2.36 million, 2%. 7 subcontractors for 8.4%, 7%. So 10 out of the 14 for a total of $10.8 million were awarded. As well, we have 4 waivers for a total of $1.3 million. The contract for health plan services for HEDIS data and reporting services for $211,000 was issued a waiver. Also for health plan services, healthcare management and analytic platform contract for $648,000. There's 2 contracts for operations that a waiver was issued. The annual life safety assessment for Stroger Central Campus in Providence for $209,000, and then the physicist and the radiation safety professional services contract, $291.3 was a waiver. So again, all 4 of those total up to be 1.359. Moving over to August, 12 contracts. 4 of those had goals, $2.8 million. Again, no subcontracting there. No prime there. 2 subcontractors, $322,000, and no waiver. So 11% for the month of August. All in all, year to date, looking at the far right column, 73 total contracts, $649 million. 15 of those for $36.1 million were prime awards, 6%. 46 were subcontract awards for $110.9 million. So all in all, 61 contract awards year to date there for a total of $146.9 million and approximately 23% overall. So Debbie, if you can flip to the next page, you have a graph visual of how that looks for the quarter, as well as the year-to-date of 23%. Any questions on the third quarter?
I have a couple. Thank you, Chair. Charles, thanks, first of all. It may be implicit somewhere on the chart, which you first referenced. How are we able to determine, relative to the contracts for which there's participation, what percentage of the given contract actually, in dollars, went to the MBE or WBE? How are we able to determine the spend? For instance, we may have on all contracts that we let 25% participation. Does not necessarily mean 25% of the dollars went to the MBEs and WBEs. So how am I able to determine the spend percentage based on this information?
Why don't we go back a slide?
Yeah.
I think some of this might be in the slide.
Yeah, so the spend percentage is based on the numbers that's presented here. And we work with the Office of Contract Compliance, which is now Bureau of Enterprise Development, for the aspirational goals. And the aspirational goals are 35% professional services, 25% and 10% goods and services, and 25 and 10% construction. So in advance, we submit them the scope of work that's required, and based on who's certified, they provide us with the goals there. So then within the responsive letter that we get back, it tells us the percentage of the goal and the dollar amount for that particular contract.
And where in this chart are we able to capture that information? Or would that be something that needs to be maybe supplied beyond this chart?
So, correct me if I'm wrong, Charles, when you look at this, maybe I'm not, maybe, just to clarify, when you go down to number of contracts with MBE is prime,
Mm-hmm.
you go to July, there's 3.
Yep.
The prime award value that is being awarded to MBEs is 2.3 million. Do I have that?
Yes.
And then, so that's a dollar amount on MBEs.
Yeah, so 3 contracts for a total of 2.3 million.
Yeah, so then you go down to the number of contracts with MBEs as sub, it's the same thing. 7 of them were awarded for a total of 8.4, so that's 8.4 million going to MBE.
Yes, and
some subcontractors.
yes, sir.
MBE
And the total is of so if you go back to the ones that have goals, so 116 million so 14 contracts, 116 million have goals. So we awarded 3% as prime. 2.3 million is only 2% of that 116 million. And the 8.4 is 7% of the 116 million.
Yeah.
Yeah, that's what I'm asking.
Yeah.
Yeah.
Yeah,
So the top number is the number of contracts with goals total universe we're dealing with, and then the other ones with the actual dollar amounts. Like if you were to look at this quarter in particular, this quarter is light on numbers for July and August, though there's a larger percentage captured in June. The important number is this fiscal year 2025? Is that the full 12-month period? Or is that
not yet. It's year-to-date to August of 2025.
Okay. All right.
So we have one more quarter to present to you for 2025. Okay. And
So-
and two, most importantly, too, you have the backup data in your package for each of these months, the supporting data.
All right, I'll take a look at that, and I may follow up with you offline just to discuss
Okay,
this.
no worries.
Other question I have
And
is,
also, just
Good.
a little housekeeping for future. We will have the Office of Contract Compliance here in a future month to
Good.
go through the process.
Good. As you may know, on the county side, I passed an ordinance, the Good Faith Effort Transparency Report Ordinance, where there's certain requirements that now any entity bidding on a Cook County contract, they must complete this report referencing their efforts at participation. And we do that to address the waiver requests, full and partial. What is our process relative to CCH? What do we require? What type of information is required before we grant a waiver request?
It would be the same. 'Cause
Yeah.
It's
Same
weird
department, same.
Your ordinance governs everything we do here because it goes through their contract.
Yeah, same department, same process. So again, we ask for the pre-goal, assessment so that we can avoid waivers, right? But that's not always an exact right. So then what happens is that, once the vendor that has a goal on it, go through all the due diligence and work with the Office of Contract Compliance, they work closely with them to try to ensure that they have participation. Then when it's deemed that it's not based on who's certified, it goes to the waiver committee for approval.
Great. Now, go ahead.
We used to have someone, it was interesting, we used to have someone who had full visibility, who worked actually in a department that was alongside contract compliance, who wasn't aware that this is something that happened under the office of the president, kept asking about, what are we doing? Like, I don't know, you go back downtown, go down the hall and ask your colleagues on the hall. But it's not a very, I think it's a common piece of this with the way we run things. We put the bids out, we collect the bids, but the compliance aspect is run under contract compliance under the office of the president, who Charles works with on a continuous basis. And I think they do a very good, I think the president's office's contract compliance department does a very good job of working with us on getting these contracts through.
Yeah, absolutely. And, we're quite dedicated to it as well. So we fund, being honest with you, we fund the, some compliance officers, so their salaries, the assistants.
And of course, contract compliance has been folded into procurement.
Yes.
So let's say that for the record.
Correct.
Last thing, relative to the information which is gathered for FY25, and I understand this is through August. At some point, will a report be made available that would reference FY25 in whole relative to this information?
Yeah, so again, what happens, the way that generally works is, once the Office of Contract Compliance have gotten all the numbers totally together for FY25, they will present to the Board of Commissioners first, and then they'll come out and present to us with the total year results. So everything I give here is just a preliminary.
Very good. I have nothing further.
I have a quick question. In that final report, will there be a breakdown, right? Because MWBE means a lot of different things, right? It's almost like saying people of color. Is
Yeah.
there a breakdown
Yeah.
of that in the final one? Or I'm missing it? I saw you look down.
No, you're correct. They normally
Okay.
break it down by,
Yeah.
the certified ones for minorities, women, white women, Asians,
Mhm.
so on
Yeah,
and so forth.
and that will be in that report.
Yeah.
Is that what we're saying?
Yeah,
Okay,
with the, Office of Contract Compliance.
thank you.
All right. Any other, these are good questions that I was thinking
Yeah, no
about as we were going through it, that if you're, unless it's been laid out, the first column and what it's describing could be confusing unless you have history with how the report is done. And for sure, take care of it. I was thinking we should have a session to break down how the report's designed and laid out, and we ended up doing it anyway.
Sure. And last comment I'll make is my current boss is the former director of that office, Ms. Andrews.
Do you want to wave? We're talking about you, Shannon. Yeah. Our Chief Equity and Inclusion Officer is over procurement here at CCH. So, all right. No other questions on this report of emergency purchases. There's 5 being presented.
Yes. Okay, all right. The first one here is issued on December 22nd. This is for the vendor to continue distribution of pharmaceuticals at CCH on behalf of the Department of Pharmacy with Mercersburg, 6-month extension of that particular contract in the amount of $66 million. reported on December 11th. This is Erin Jane, RN, a 6-month contract, $150,000 for the vendor to provide services to access and make recommendations on alignments of our nursing leadership and the role structure with system strategic strategy relevant to the national search for our CNE in the Department of Administration. We had one for Norton Rose Fulbright, U.S. LLP, 12-month contract with legal services, $149,000. This vendor will provide legal services for our RAC audit appeals, and this is on behalf of the Office of General Counsel. Contract with Samani Ali Khan, MD, 36-month contract for the Department of Dermatology, $317,000 to provide locum tenens service as a Mohs surgeon for the Department of Dermatology. And lastly, a contract with Sohair Ahmed, MD, independent physician, 9-month contract as a GI services, $445,000 on behalf of the Department of Medicine. So those are the 5 emergency purchases.
Any questions on any emergency purchases?
So for the, contracts with the providers, we're gonna move those over to the, okay.
Yeah, they'll come in the local.
Yeah,
Yeah.
the vendor for the, nursing services is an individual. Is this a company or an individual?
It's an individual.
Yeah.
Yeah, a former CNE.
Oh, she has, yeah. So a firm is gonna do the work, or she's gonna do the work?
She'll be on site, but through her, yeah, through her. All right. Thank you, Charles.
I thank you.
We're now going to go to the interim CFO, Scott Spencer, who's going to report on items under the Chief Financial Officer. And we're going to start with item number 3C, receive and file grant award related items.
Good morning.
Morning.
All right, so Scott Spencer, interim CFO. So we'll start with the receive and file reports. We've got 5 grants here for a total of $2.4 million, with about 80% of that coming from IDPH on the second and fourth row of this report. So any questions on those?
Any questions? All right. So no questions on any of them. So we're going to, I'd accept the motion to receive and file the grant award related items.
So moved.
Second made and properly seconded. Any discussion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right, we're now going to go to our report on the November year-end preliminary financials.
Yep. Yeah, thank you. So the 11/30/25 preliminary financials, and preliminary from the point of view of we got a handful of entries that we still don't have yet. They come from downtown. We expect to get those in a few weeks, but this is normal course of business for this time of year. So next slide. Thank you. All right. So ending at, on accrual basis, $128 million unfavorable to budget on an accrual basis. However, just under $82 million favorable on a cash basis. The drivers remain what they have been for most of the year, and that net patient service revenue has been lower than budget due to lower than budgeted volumes and increases in charity care. However, capitation revenue continues to be better than budget. And then, as you'll see in the next couple of slides, county care financials coming in unfavorable to budget, driven by a medical loss ratio higher than budget. So next slide. Previous slide, please. Yeah. So we'll start with the combined income statement, and this is the view that you're used to seeing. And starting at the top, again, the net patient service revenue unfavorable by 265 million. But as we add in the capitation revenue, that's favorable by 358 million. We have total revenues favorable by 90 million. And then as we work down through the expenses, total expenses, 214 million unfavorable, driven primarily by the medical claims expense, offset partially by the salaries and benefits, bringing us to the net loss of 131 million combined. And then on the right-hand side, just highlighting a few of the items that we're still working on or waiting on. Things such as pension and benefits adjustments that will come from downtown, property tax true-up, and then we also like to spend extra time with the year-end numbers, just making sure that our accruals are all buttoned down and that our accounts receivable reserves are properly stated as well. So don't anticipate much change there, but we do give it a second and third look. So the next slide splits out healthcare services from health plan services. So this is a new view. On the left-hand side, we have healthcare services, which is HCS, and on the right-hand side, we have HPS, which is health plan services. So in the bottom right-hand corner is the same 131 million net loss that showed up on the slide we were just looking at. But again, it's broken out healthcare services from health plan services. So you'll see at the bottom of healthcare services, HCS, a net income of just under 33 million. And then on the health plan side, a net loss of just 164 million. So just wanted to highlight that, as you're all well aware, we had mid-year cost-cutting measures that were put in place. So if we go back to where we were about the May-June timeframe, had those cost-cutting measures not been put in place, it's easy to see how we would have ended up with a net loss of in the neighborhood of 200 million on the healthcare side, and of course that's not where we landed, with the again showing the 33 million of net income on the right-hand side in that HCS column. And we'll talk a little bit more about that on the next slide. The waterfall report here. This is combined, so no changes in presentation here, but it highlights the favorable, unfavorable drivers for us. So the patient service revenue and the medical claims expense being the unfavorable drivers, and then the favorable drivers being the capitation revenue, and then the salaries and benefits and the purchase services and other. On the next slide, volumes, largely the same as they have been all year. So coming in short in terms of average daily census, ER visits, and surgeries. Surgeries at Provident has improved over the last few months as the GI activity has picked back up. And then also wanted to highlight that the surgeries at Stroger in November of 25 of 856 is a pretty nice improvement from a year prior of 728. On the ACHN side of things, primary care visits end of the year where they have been all year, short by 8%, but as a reminder, we had Belmont Cragen budgeted for the full year. And then specialty care visits also landed where they've been all year for the most part, which is favorable to budget, just under 5%. So the next slide, our operating trends, just showing that our volumes overall have been relatively stable over the last 5 years. And then moving on to the next slide, a payer mix. Showing Medicaid at 51.4%, which is a 0.2 of a drop from last month. But I think more importance to highlight is the 10% drop from the high water mark of Medicaid, 61.4% in 2023. And then uncompensated care at 22.3%. Revenue cycle KPIs.
I'm sorry, can we go back to that chart?
Mm-hmm.
Do we have any thoughts as to why that we're seeing this drop? Because this is the biggest source of revenue for the hospital, right?
Yeah, correct. And it's the impact of redetermination and the elimination of programs like HBIA and the freezing of HBIS, so health benefits for immigrant seniors. But the HBIA and the redetermination has impacted that number as well.
So it had an overall 10% in the Medicare category.
Yeah, correct. Yes, which is, and as you'll see later in the deck, is driving that additional charity care
So that was
that we're providing.
That makes sense, I understand that.
So that was the primary driver of that $200 million loss on the provider side of the organization that we were able to kind of swing into $30 million profit. That was the belt tightening and all the stuff that we were talking about back in the summer. Unfortunately, we're probably going to continue to see those trends of losses in Medicaid. The Affordable Care Act tax credits, or the subsidies, are going away as of now. We're anticipating 35% of folks covered under that product through the marketplace are going to forego coverage because their premiums are going to go up by like 95%, I think is the average.
That's for the ACA.
That's ACA, marketplace. And then going into 27, we're going to see work requirements and doubling in cadence on redetermination. So instead of annual, it'll be every 6 months. So there's about a 10% in each of those buckets that we're anticipating additional losses. So it's going to be 2 more years of this type of trend where we're going to continue to see people losing Medicaid coverage.
Okay.
And we should say too that, you know, just as a public policy, like some of the things that they're layering on top, like work requirements and things like that, there are people that would be able to still be covered under that, but by layering these new, you know, checking the boxes and forms, people who could still meet eligibility because of, you know, their inability to work or things like that, that would eventually be taken care of through applications and forms. It's going to all get to be too much for people, right? And there's people who don't have access. There's so much. We could counsel people and figure out how to get coverage, but the federal government's doing whatever they can to discourage coverage and participation in these programs.
So then the question becomes, should we look at a cost analysis to understand, is it beneficial for us to set up a system to help those individuals check those boxes versus allow them to just fall out of the system?
I'm glad you're asking. So that's the Medicaid Impact Work Group that we've pulled together. So we have health systems, we've had health plans, and then even, business leaders, technology leaders, education, academia, in the conversations. We're actually spinning out work groups at the end of this month to focus on how we're bringing resources together to ensure that people, as much as possible, are able to maintain their coverage. So we're doing that through the health system, and then we're also doing, through President Preckwinkle's leadership, and NACO, National Association of Counties, we're actually going to be out there in February, and we're doing the large urban center caucus meeting. We met back in October in Milwaukee with Hennepin County and Harris County. So we're starting to have more kind of that political sphere of how do we align people, get everyone to understand exactly what's about to happen, because I think there's been kind of a general lack of understanding of just how deep this impact is going to be, especially for systems like ours. But also from kind of a constituency standpoint, right? Red counties, I've said this before, red counties are going to get hit harder than blue counties even, in terms of some of this coverage. Particularly rural. Exactly, yeah. So ensuring that we have alignment where people maybe are on opposite sides of the aisle, but understanding that impact and ensuring that we're messaging that and finding the right lens to kind of communicate that to, sometimes disparate groups, right? So we're working through that angle as well.
And
at the
we
county
should,
level.
and we should note that the board's getting updates on the Medicaid impact group. We're getting emails on that too, so just continue to track that in your email traffic. So it's a real time update. It's coming from Debbie, and I think Kathy Chan was developing the report.
Give me a re-forward the last message that went out. It was like a few days ago.
Sure, yeah. Thank you. So the other question, this also, Scott, this brings me to, when we look at, go back, Debbie, if you go back 1, 2 slides. One more? Okay. I'm not gonna say what I always say here. I'm gonna say something different. If we look at the numbers, we see where we're losing money. So the question becomes is how can we get the census up, which is always the major question of any business, right? So then that becomes the question of Alex, my favorite person to call. How are we addressing this issue? Because this issue has been systemic since I've been here on the board. So how do we overcome this? Because it has to be marketing. Because we have to figure out a way to get the people to want to use the great service that we have.
So I would say the biggest shortfall, yeah, Alex, why don't you come up and while you're coming up, obviously the biggest shortfall, as you're pointing out, has been at Provident. And we've done market analysis. We've had community feedback on kind of the perception of services there. To that point, there's been, I think, a lack of awareness, perhaps, in terms of what we're capable of doing at Provident. So there is a push now that I'll let Alex kind of talk about.
Yeah, thank you. So for Providence specifically, we did, I would call it a mini campaign earlier this fall to promote the services. And then starting this month, we have a significant media campaign to promote Provident and all of its services specifically. So that includes digital advertising, out-of-home advertising, a postcard that will be mailed to the entire Provident catchment area. We're doing a takeover on the 51st Street CTA L train line, so that's coming up in the next month. And we really want people to know that they've got expert care right there in their community. We're promoting adult primary care, and then some of the key specialty services that we know we have capacity to fill and community need.
So how do we overcome because who are the competitors there? University of Chicago. I don't think Jackson Park is really a competitor for people who are paying for the most part. Maybe I'm wrong. South Suburban, does South Suburban present an issue?
We've got Bernard's in the mix too. They're a little closer. St. Bernard.
St. Bernard, they're all the way over west.
They're in the mix. So.
And I'll note that
For paying customers, they're competitors.
Well, everyone has a payer mix, right? So there are.
Yeah, they've certainly got a mix of both Medicare, Medicaid, and some uninsured patients. I'll also note that we're seeing increased activity in the Bronzeville area. Northwestern just opened a really large,
very nice
beautiful,
facility.
new facility in Bronzeville. And so, I think that informs how we're strategizing about the South Side and where we can continue to fill gaps in access to make sure that people know that we are there. But I expect that we'll continue to see ongoing, I don't want to say encroachment in the South Side, but it's definitely a market that is of interest to some of our larger nonprofit competitors.
The way things have sort of situated themselves with Provident over the years was there was first a disinvestment in the type of services that community health would need that now there's been gap filling by institutions starting to, like I said, encroach on there. Our response was to, we've scrapped a lot of different capital projects over the years, and then the more recent strategy, which I think was the right one, was to reopen the emergency room to help drive patient volume and also fill a need. I think we all know about the history of emergency room visits in that area. When University of Chicago was going to start turning people away at the ER, we number of different reasons, has been slower than what we wanted. I think we've talked about that here, is that one of the issues in terms of being able to effectively drive the census numbers up at Providence was to make sure that we had the staff to accommodate the census and the amount of patient beds, which has hit road bumps, speed bumps. And I don't know if you want to talk about that and where we're at in order to, because like, we can have the best marketing plan possible, but if we're also, because we've had to transfer, there will always be like taking people to Providence and then sending them to Stroger, right? There's going to be cases of that, because Stroger has one of the preeminent like burn units and things like that.
Right.
But do you want to pick up on this thread?
No, absolutely, thank you. And I would say, you know, even to kind of pull the thread even more through, there are some functional limitations there too. For example, we don't have a cath lab at Providence, right? So we can't take semi-calls, so any heart attacks are obviously diverted out. They don't ever come to Providence, right? And similarly, no IR lab, those types of things. So if they do present with that and it ends up being something, to your point, we have to move them to Stroger, right? So, and it probably happens more than it needs to happen in terms of surgeries and such. But to come back to the ambulance point, you know, we looked at volumes recently and we're under one run a day right now at Providence. The ambulances aren't coming either, right? But we do have a multifaceted kind of operational plan. Craig, I don't know if you want to come up and talk a little bit more about it.
And by the way, this is not to say that we want to drive patient volume just through ambulances, because there's other community health strategies.
Well, yeah, most of the volume is one.
Yeah.
Really most of this year to try to continue to build the volume at Providence. We've identified opportunities around certain specialties that we need better coverage there, which will allow us to retain more patients at Providence. We're working, right now we're reintroducing GI services at the hospital, and that will include both procedures in the operating room as well as consults on the floor in the ED, which we think will retain some patients there. We're looking a little bit around neuro, which is complex. We provide telestroke coverage there, which should be able to hold patients there. But with the EMS regulations in Illinois, unless you're a stroke designated hospital, you don't get into EMS service. So as Eric mentioned, there's a number of headwinds in terms of that. So a lot happening at Providence. The other thing I did, Director Robinson, want to mention, and if you remember back in July, we did a deeper dive on volume, but on the Stroger side, you know, the 4% is that 3.6% miss on average daily census. So average daily census is really a cost driver, right? It's a measurement of the number of heads that are in a bed every single night. And that means that when we have a head in the bed, we have to staff. Now, we don't get paid based on days, we get paid based on discharges. And what's actually, that red number is kind of a misnomer, because we've actually seen a huge decrease in length of stay at Stroger this year. So actually our discharges, and I have data from July, we should probably look at it, Scott, at the end of the year. But through July, we were 2% ahead of budget on actual patient admissions and 10% over prior year. So, and that's really the work of Donegal and the team at Stroger. They've been focused on ensuring that we're getting patients to the next level of care, getting them discharged to home as quickly as possible. So while that does look like a bad number, a red number up there, it's actually a very positive number for the system, and really the result of a lot of hard work by the Stroger team.
Yeah,
and Scott, I wonder, honestly, I wonder if we want to start having discharges as a KPI up there, because it is really the revenue driver for us.
Yeah, and that was we ended the year at Stroger 12% better than budget.
Yeah.
As far as discharges go.
So in terms of marketing, like 12% more people are coming to get care at Stroger on the inpatient side, you know, versus budget year over year. That's really good work.
The biggest challenge I think we're going to have is on the payer mix, is that our payer mix is going to get upended, and what we can do to drive a higher census at Providence is still real, but it is a smaller smaller percentage of our overall census as it is, it should be more robust. One, because there's still a community need that's underserved in that area. And, you know, the amount of people who see a barrier to go walking into the University of Chicago.
So then maybe the question becomes, what does Providence do well? And then how do we let the people know what Providence does well? Because what the problem I'm trying to solve is, how do we get the people in the door? Because we stated that we can do X, Y, Z. So we've got to find out a way to get the people in the door. I mean, if we got to scrap the entire strategy that's been used, then that's fine. But we can't have 3 years in a row saying the same thing and nothing happens and it changes.
Yeah, so one of the things that we're doing is, it's not even just external, it's internally, right? So, you know, we talk to the primary care medical homes in the southern region of our footprint, and they're like, oh, we don't know what can be served at Providence. Like, what are their capabilities there? And so Dr. Turner's gone out to all of the primary care medical homes, met with the primary care physicians in those practices to really talk about, here's where Providence is today, here's what we can handle, here's the type of discharges we discharge every single day, here's our capabilities, here's where patients that come to Providence we have to transfer out, which is, you know, is not as much. And I think so we're doing a lot of kind of internal marketing around having our medical staff understand the current capabilities of Providence, the value proposition of having a patient go to Providence versus coming to Stroger. Like, the chances are, if you see a patient at Blue Island and they need to go to the emergency room, likely they're going to have a longer wait at Stroger, and likely they're going to have a longer commute to get to Stroger. And so, you know, how do we kind of create not only that advertising, then we've also set up some internal communication mechanisms. So if they are sending a patient to Providence ED, they can send a text message to our ED staff. So when that person arrives, oh, Director Robinson, I'm sorry you're not feeling well today. We got a room ready to you, and really try to bring that forth. You know, it's not happening every time, but those are the types of things we're working on to really try to do.
Craig, if the discharges are an important KPI, I think you were giving us the system-wide number or the Stroger number. What's the discharge number at Providence year over year? It's down.
Yeah, here somewhere. Yeah, it's, I'd have to confirm that for you, but yeah, it's down.
Can you give us a 5-year look back at it to see where we've tracked? Because it could be down, but it could be down negligibly. It could be plateauing. It could be up.
I think it's probably well. Let's look at it.
Yeah, let's pull the
I
numbers.
think it's flat.
We're doing the deep dive for the Providence division in February to the full board. So we can, yeah, we'll pull the whole.
It's been a nut that a lot of people have tried to crack over the course of the last 10 years. So, I mean, we've had, like I said, scrapped capital projects, things like that. Oh, and Chair Garza, I think, wants to weigh in, either ask a question or weigh in. Rob?
Yes, thank you, Chair Ryder. So I wanted to go back to Director Robinson's initial question about market share and what appears to be a declining market share. I guess, as I think about it, I'd want to know, how has the market changed over the same number of years that you want that same analysis? Because if the market is diminishing, and we know it will, we know it has, because the community that Providence resides in is a changing community. So my sense is that there's less of a Medicaid, probably even an uninsured population. So I think that has to be factored in. And then number two, just, everything that we've seen happen over the last 7 months with HBIA, because that's no longer a sector in the market. So that diminishes the market. So I haven't heard any conversation about that part of it. I don't think you can just take a straight line analysis and say, what is our decline look like, without looking at what is the market's decline? Is our decline steeper than the market's decline is? I think that's a critical part of that analysis.
I think it's a great point. Chair Garza, we'll try to, I think, bake in a market market analysis in addition to
Yeah.
volume trends
I-
into the February report.
Well, yeah, because otherwise you're taking unfair, I don't know if it's criticism or focus on, our market diminishing, but if the greater market is diminishing because of idiosyncratic factors like a changing market within Bronzeville and a changing market within the state of Illinois and federally, it's got to be factored in. So I appreciate that analysis.
But if we're looking at, and I think this is what you're driving at, is changes in income level, changes in access to private health insurance, which I think
Yes.
anecdotally is happening through like different sections, like in Bronzeville, Kenwood.
Yeah.
In parts of where the Obama Center is going to go. It's not happening now. It's going to continue. It is going to continue to drive. It's still a good location though to do community health as an access to the west side and the south side, and the near southwest side.
Yeah.
I say west side. I'm thinking not west side, but west of the hospital.
Dan Ryan.
Following towards Englewood. I do think it's very salient because I don't think we want to build a new hospital 5 miles to the west. I think we have a good asset there to build on, but we should think about how we access it. So I'd be interested to see how that is played out. I don't know who we would have what we would need to tap into to look at that market analysis of three. You guys can figure that out.
Yeah, we have resources.
I want to offer up a different concept and use a term that people are familiar with, gentrification. It's happened throughout the city of Chicago, and some neighborhoods changed dramatically over time. The West Loop is one really clear example of how things have changed. Growing up, the West Loop was Skid Row for the most part. But now it's gentrified, it's changed, and they have a base of people that people want to market to. They're younger, they have income, and what's happening both in Bronzeville, will happen potentially in Woodlawn, is there's going to be gentrification. And as gentrification occurs, there are people that move into neighborhoods because there's opportunity, but they're also bringing income in that hasn't been there before. And so Northwestern wouldn't be establishing a clinic there unless they knew there was a population that actually had the coverage, and even if they lacked the coverage, had the money to pay for care.
Are you saying that Northwestern as a not-for-profit and a research hospital isn't going to plow a bunch of money into Bronzeville or try to look for access to
I think it's
Woodlawn?
opportunistic.
Yeah.
I think I would.
Oh my gosh.
I just sold my home on 49th and Business.
Someone said to me that sometimes in order to maintain their not-for-profit status, they print a lot of fancy flyers about how people can be healthier in order to meet that goal.
So one of the things I will say at the former place, as a former resident at 4936 Vincennes, and that's right behind Providence, there is a different level of resources that are moving into that area. Also, the former place I came from before I left to practice, the two places, strategy-wise, that we came up with was the actual spot that Northwestern sits in, and the Bronzeville, ironically, the Bronzeville building that Cook County now has. Those were the two spaces that the former place I used to work at were looking at, and those were the two spaces after we did the assessment. We were in the mix for purchasing. What I'm saying is, one of those spots that went to Northwestern. The other spot, I'm not sure, I apologize, I don't know what's going on at 31st, maybe it's just admin, but.
The Bronzeville Center, like that, it's an outpatient center. We have physical therapy, occupational, the family medicine, behavioral health.
Because that spot, if you go to the, I thought it was that, but then I didn't hear it. But if you go to one of the corners, it overlooks beautiful scenery. I will go back the opportunity for some type of program or service line that attracts and we can talk more about what we did the needs assessment, what those people want. There's service lines that are going to attract those residents into that space. Because of the much needed work we do, sometimes those service lines may get clouded because we're so busy offering so many needed service lines. The other thing that I will say, you say you won't say something you say every month. I will say something I say every month. Virtual health is definitely, and when I first said it, I didn't know that the opportunity was going to present itself like it is now, because there's differences in the market that was interested in virtual health right now and that we were talking about then. Certainly needed. We don't want to, we don't want to overlook that it is included and probably prioritized before this next statement. In these next, we got 3 years. Over these next 3 years, the exact population that has those resources is going to be, unless it's like an aesthetic, which a lot of the aesthetic things also help the heart and things like that. They cut down cardiovascular stuff, so it's okay to offer them at the Bronzeville overlooking the lake. But also, they'll be interested in virtual health because of the climate that we live in. And so there may be opportunity to diversify the resources now that are offered on virtual health. And this is coming from someone who, the actual space Northwestern sits, the actual space the county bought, virtual health is an option. And also expanding some service lines that will also help to optimize, well, I'll stop there. That may also help to optimize some of the time spent in FTE.
We lease that space, right? Or did we buy it?
Yeah, we subleased it actually from Outfront.
Yeah.
Oh, they did.
Yeah.
That was what it was. Okay.
That was
outside Howard Brown.
That was a good.
That's exactly.
I knew that, yeah.
That was a good piece of property. The irony is that we had two well-known Chicago hospital institutions in the very area that are being flooded. One that was taken over by a private company, and one that's where people are looking for a development aspect for that land. And those two hospitals would have been able to hang on in their original incarnation. They'd be thriving right now in terms of Michael Reese and Mercy.
Yeah.
So I want to move the conversation, but before I do that,
May I ask Craig one question before he leaves?
sure. And then I have one last area that I'd like to see a hospital. So
Okay. So Craig, think about this. Would it be possible, given things that have been stated and some of the ideas that you put forth, to do a revamp of how how Providence looks and the service quality? Because if the demographics are changing, then those are the things that will speak to the demographics.
So we're currently wrapping up our long-term master plan, which is looking at all of our facilities, hospitals, public health, as well as CCHN, and we'll have recommendations on kind of how we think we should position Providence. The other thing is, and you all approved it here, is the Providence Construction Manager at Risk contract, which has a lot of cosmetic updates to the physical plant at Providence, like the whole, when you walk in, that whole front lobby is going to be completely done over the next year. So kind of doing both, like thinking more mid to long term, as well as what can we do immediately, really refreshing that plan. And we've also done a lot to really try to look at like landscaping and plantings, and I think if you haven't been there, I wouldn't say go in January or February, but like the spring, we should probably have a refresh, go out there and have a walk around, because it is a much better condition than it's been probably for a long time.
And I will say what Dr. Turner's doing, going out to them, now that's fantastic information, because that can move the needle. That's actually excellent.
I think over the course of the last 5 years, we've been moving in the right direction, but it still has shifted a little bit. So it's about all that. What's that?
The numbers aren't showing it. That's
Yeah.
the issue.
Yeah. Well, sometimes something needs to move to that. One thing that taking a little shift, there is, I believe, still a space for us to fill in that area. And one other space I think that we need to fill. This is, you know, there's a lot of consternation over whether Oak Forest was properly serving things, but if we need something in the southeast part of the suburbs to serve the communities that, you know, Blue Island isn't necessarily south enough to hit the needs of the south suburbs. Blue Island's a great facility, has a lot of impact on, and, you know, can stretch into Cal City and things like that. But I've got communities down there by Chicago Heights and Fort Heights and, you know, Lansing and, you know, Madison or Madison. You know, there's hospitals there, but it's becoming, the health access to healthcare is getting stretched. And, you know, your public health, I think, and public access to safety net hospitals are getting stretched. I think, you know, there's the ones that are down there like Franciscan and all that, they're not true safety net type of institutions. Eric?
Yeah, well, I don't disagree. I would say just looking at, you know, we talk a lot about the west side and the 20-year life expectancy gap, right? It's the same thing in the Southland. I mean, it's 65 versus 85. When you look at, you know, Southland versus West Loop, the outcomes, disease-specific, cardiac, diabetes. So, I mean, yeah, I mean, that's
Call it the Lincoln Highway corridor.
Yeah,
would be, I think needs to be served by us. And, you know, the county board president has spent a lot of time trying to build opportunity and income in that area too. So I think it's mission aligned as well.
Last thing, you know what was really interesting when we were looking at what we're gonna do, it was easier to have people come in when we noted that it was lifestyle medicine, even though it was diabetes, hypertension, managing, you know, like those type of things, than when we mentioned it like they're at risk for diabetic outcomes. So that may be interesting to look at, you know.
Bill, we're gonna, before we move on, you get the last word on this section.
Thanks, and I get we need to move on. I just want to say, I still believe you build it and they'll come. And we have to be, we have to embrace that over the last 2 or 3 years, we have resumed ambulance access there.
Well, it's your community too.
Well, I appreciate it, and it is. The dialysis center, MRI center, the GI surgeries, the behavioral health stabilization unit, Brownsville Health Center, Providence Scholarship Fund, all of these initiatives, and as well as the brick and mortar, we're just talking several years. In the community, they don't know it. That's why I think that the campaign is well timed. I think that with a sub-campaign focusing on not only the community members and organizations, but the churches, we can start getting this messaging out. And so we need to be purposeful, but I think the opportunity is now, and I'm glad that we're doing the campaign.
And that's why I asked for Alex to come up, because I agree with you. I totally agree. And I think Alex can do it. Well, and there's a lot of good partners down there that we can drill into, like Push and Trinity and all that. So, okay, Scott, where are we at?
Slide number 9.
Okay.
Right, so our rev cycle, KPIs, a couple things to highlight here, cash collection.
I got one more heavy report, so we gotta get your riding shoes on.
Move swiftly.
Yeah.
All right, cash collections, back at target, for the month, and then a couple things to highlight on the accounts receivable, both, in total and, the AR over 90, rev cycle team has done a tremendous job of getting those claims, resubmitted and paid, and where they can't be paid, they're written off. But in any case, the AR days is back to target, so in a much healthier position. And then on the next slide, government billing denials continue to be in good shape, and then our net final denials at 0.7% is well below the target of 2%, yeah. So, congrats to, Curtis and team. The next slide here are charitable benefits and community, programs here. The total of 629 million, about 10 million lower than we were estimating, a month ago. So, if there's, a bit of good news that's coming out of that, I guess the slight decrease is that. But of course, driven by those top two lines of charity care and bad debt. Our next slide, our savings initiatives, just a couple things here. Our goal was 28.7 million. We achieved 48.6 million, so almost double, 70% better than the goal. But just highlighting the last line, the vendor contract negotiations, which really is the agency savings. So we had targeted 20 million, and we came in just under double that. And then last but not least, we've got the county care slide with the operating loss of 149 million, which, again, the case remains the same there with the medical loss ratio higher than budget, and then the conversations with the state are ongoing as far as the risk adjustment and the impact that has on the rates that the health plan is receiving. So happy to answer any other questions you might have.
Any other questions for Scott? If not, thank you, Scott. And we're going to move on now to our last item, which is an informational report from Craig and Wynn Buren. Wynn's again, our Chief Human Resources Officer.
Hi, Craig Williams, Chief Operating Officer. This is our report on agency utilization. As I think we all recall, we started reporting on this back in the end of FY24 in September, and we continue to see a pretty significant decline, even month to month, but certainly I think we're down, what's the number, 47% from the start of this initiative, and we keep November was again a further decrease. We're actually below for the first time a 10% in terms of number of people who are here on site every day, number that are employed versus number that are agency. Just under 10% of the staffing is agency staff at this point, which was closer to 19% when we started this effort. Next slide.
And a reminder, those are live bodies.
Live bodies. Yep. This is the same information, just cut by job codes, and what I would say is, we continue to make reductions across every category. When anything worth noting on the clinical nurse?
Nursing's probably where we're at the highest, but anecdotally, about 90% of our job codes are below 20%, which is a goal of ours. So across the system, we're below 10%, but there's only a handful now, a little bit more than a handful of job codes where we're still above 20%, and some of those will play into what's the threshold of how many people are in that department, right, or in that job code. So we've made good progress there. We're continuing to work through the nursing piece, and then obviously, I think the other one up there is the 74 folks, and that's probably through the Absent Guide Health settlement. Yep.
What do you think is a significant number in terms of that metric?
Five
job titles with 5 positions or with 20
and that's the challenge, right? So that will always kind of kick up and say, if you have 5 positions and you use 2 people, you're already over that threshold. So we've got to think about what's a realistic goal. I think we're getting pretty close to it. I think once we are able to get nursing down below that 20%, and we take care of the items online too, the health management coders, I think that's where we'll be at a point where we feel like we're in good shape.
Let's also add in there the revenue, because this is finance committee, and the biggest number is clinical nurses, and I would imagine that's the biggest dollar value as well, and that's pretty important.
Yep.
I know that we want to get below 20% on everything, and I think that was originally what the county board was pushing towards 20% in every category. Again, I think we talked pretty, we've explained pretty impressively, like if you had a five, just 5 positions and a job title, and 2 people quit, or 1 retires and 1 quits, you get upside down real quick.
Right.
For nurses, where do you think, once we, what's the number that you guys think, and this is to Eric too, where should we be at in terms of agency utilization? Where do you think the sweet spot is? I mean, 20% is a number that people throw out.
I think we're working on getting some benchmarking data as well to understand what's going on out there. I don't want to just throw out a number and say, hey, this is the right number because we threw a number at a board. I think we're getting closer to it. I think we can cut that number that we see up there in half right now, so that'll get us really close to that 20%.
So for nurses,
between agency conversion and then continued accelerated hiring within nursing as well. Do you want to talk a little bit about those numbers? We've got the job fair coming up for Schroeder. Yeah, we've got a job fair coming up. We just had a job fair.
So before we jump into that, so you think it's somewhere in the ballpark of just lower than 20%, but somewhere in the ballpark of that?
That's what I think would be sustainable for us right now, based on what I've seen and based on where I see our numbers coming down over the last year, and then the settlement agreements we have in place. I think that's a realistic number for us to go after.
The other piece of that is seasonality, right? There's times where we need to staff up, and it makes sense to do that through an agency. Utilization as opposed to hiring, full-time equivalents are going to be here for the entire year. We don't need those bodies.
It's a different, and I understand it's a different service line.
Yeah.
More sensitive to patient volumes.
I mean, even within this number that we're looking at now, from a conversion standpoint, I believe, and RJ can correct me if I'm wrong, we've made 57 offers out of this group with conversion. So 57, we've made more offers than that. We had 57 people accept. So we'll see those numbers start to go down over the next few months. And then obviously we'll start accelerated hiring, and then we'll see how that goes as well.
And the Schroeder job fair, I think.
Schroeder job fair on the 22nd, and then we just had a CERMEC job fair where I believe we hired upwards of 30 folks as well. So we're seeing those numbers haven't hit here yet because of just from a timing standpoint. But as you see these, as we start to onboard, we'll see those numbers come down. We'll also have to start to mobilizing some of those agency nurses as well.
Craig, I take your question to be more like, what's the good operating number, and where do we want to be able to flex to with them? And I think Craig understands this part from an operational standpoint quite well. We've talked about this in the past. I'd love to hear what you have to say about this.
I'm hesitant to, I don't directly oversee the nursing team, and so I'm hesitant to opine on what the actual number is. But I've worked in government healthcare now. I've worked in not-for-profit healthcare. I've worked in profit-based healthcare. And what was interesting, my one time when I worked for a for-profit, I was always super anti-agency, contract labor, overtime. Like, we got to push it out. When I got to the for-profit, they were really more focused on actually using more agency to deal with the fluctuations of volume and just to create more flexibility. And so to me, that was a new education for me around how do you really, sometimes you have to spend money to make money to be able to, flex your staff and be as efficient as possible. So I think there's a piece of that. I'm hesitant to say what I think the right number is, but I think there's benchmarkable numbers. I also think the numbers around agency utilization are coming back to a more industry-wide kind of stabilized metric versus where we were during COVID, where everybody it was the wild, wild west, and everyone was just going out, and people, I think, seem to be looking for a little bit more stability at this point. So.
And I think one of the key factor when we look at this report is, again, acknowledging there's the size of the job title classifications, and then and I think, Craig, you and I talked about this along with Eric, there's some things that we were using agency for, were like way overextended on agency. It's like, this doesn't even make any sense. Right? Like, this got way out of hand too quickly, and now it needs to be reined in. That's why the agency is also being managed. I mean, I think we talked a lot about what we're doing to hire and do the conversion, but I think one of the reasons why we got into this space where agency utilization across job titles was the decentralization of expanding service lines through agency that we've now reined successfully have reined in on top of that. And that was actually the first that was what we started doing, and you guys got the number down first by taking control. And the conversion is what's now accelerating it.
Yeah, I mean, we spent 45 minutes this morning on the agency review committee, ARC. Everything has to have an acronym. You know, and honestly, like, I feel like we're too tight now. Like, I'm constantly fighting Win around trying to get the agency staff that we need because we have, you know, real vacancies. But, you know, at the same time, I know I have to come up here and present these numbers. So, you know, the challenge is, you know, getting people who want to come to work here, converting on those people in a timely manner and getting them onboarded and being able to, I mean, the great news is we have a lot of demand for our services. And so what we want to make sure is that we're not standing in the way of demand because of staffing issues. And so that's, I think, the balance that we have. It's a healthy tension, but it's tension.
And I think, Craig, part of the challenge that we had at this, well, one, if everyone remembers, we spent about 6 months, maybe a little bit less than that, just trying to understand the numbers because, to your point, it was so decentralized. There wasn't really a handle. So I mean, just getting going on this took a minute. But the hiring piece, the front end of our funnel to get people in, has been where a lot of that focus has happened. And I think it's telling that 4 years ago we had lost 120-ish net employees. The year after that, we were essentially break even. I think it was like -2. Last year we were 265, something like that. And then this last year we just came in and just shy of 500. It was like 465 or something. So I mean, the net growth is on a really nice trajectory as well. But what we're also seeing on turnover is that we're pretty low. I mean, Bina has shown nursing numbers. Once we get people in, they tend to stay. It's really getting them in has been the challenge. So, and that's been a lot of work with the HR team.
Well, I think that it's okay to use the agency staff strategically when you're being entrepreneurial or when you have a crisis situation, you know, a care issue. It's just doing it, like you said, in I think the Wild West with no rules or boundaries or accountability is where, and it caused huge morale issue, which I think has improved dramatically in our relationship with our rank and file leaders from our staff. I think has improved dramatically.
So let me be transparent. I'm not
with a few notable exceptions that we've worked our way through.
Thank you, Chair. Let me be transparent. I'm not speaking to Craig today because I found out yesterday he's a New England Patriots fan. So this question is going to be posed to you, Win.
My second team is the Bears.
Relative to the hiring.
The Bears aren't second to anyone, ever. Now I have 5 after you.
I opened up. Speaking of hiring, when is the Stroger fair scheduled?
January 22nd.
Thank you. That's all.
And when, I know in the human resources, you told us about a fantastic program, how you guys are attaching. So everything that I am saying is with that in mind, because I have full confidence that you guys are going to make it happen. The program that you set in place and the way you presented, it was just fantastic. I know I already thank you and everything, but it's worth saying again because to start off the new year knowing that's where you guys are going, that's fantastic. I asked Craig because I share Craig's understanding of strategic need for the agency to be able to flex, which gives you the coverage to be able to get the people in so that then that amount can be reduced. It's almost like a semi-batch. You go so far, then you're going to have to open it up, you're going to have to do something to change over the process. And that's what that agency can allow us to do, changing over the process being giving you the time to hire the folks without losing business and service going unmet. So I think the combination is fantastic. So don't take anything I'm asking to be a negative. It's not. It's all very positive.
I appreciate it. I think we can move on, Debbie. This is locum tenens, which is provider, temporary providers. This is a number that actually we haven't made a lot of progress on. It's been pretty steady state. There's a lot of work happening under Dr. McCormick and Dr. Smith to really look at overall physician compensation and planning around that. And I think that will really start to move these numbers. I would just say it's been steady and it's been really focused to make sure that we can continue to provide needed services.
Thank you so much for that. I know that the pediatric, the dermatology, the GI that was mentioned are going to be added as they start. Those were the ones that were mentioned earlier poorly. Also, if in the past there were ones like OB-GYN, things like that, are they all going to be added as the person starts? Is that what I'm looking at? Or is there going to be an effort to go back and look at how many emergency contracts and other contracts we've recently?
So this is compiled by our medical affairs office, and all of those contracts should be emergency or an outside locums contract should be coming through that. I'll actually take the ones that we put through this month and make sure that they're reflected on here, but that is my understanding that, this is a true depiction of where we are.
Okay.
But I will actually check on those. Because as you asked it, I'm like, so good Catholic guilt, sorry. And then Dr. Sprenka, yep.
Good morning, directors. This is Mark Spranka, Chief Scientific Officer. Happy to report
Just a little
continuing.
closer to the microphone.
Happy to report continuing progress on the staff who once were sitting at Hectone, who then shifted to MedX. We've been working through the process of posting positions, interviewing candidates who've applied, and then processing those applications. To date, we've got 46 or 43% who've onboarded to CCH, with a bunch more slated to onboard later in January and February. We expect 90+% of the folks to be CCH employees by the end of February. Though there are a few stragglers that will might take a little bit longer to process. We're working through it's various issues with various individuals. Some of it has to do with is the grant fully funded to support this person through the end of the grant, and that involves budgeting and rebudgeting and getting sponsor approval and clarity. But by and large, we're going to get all these folks, with probably just a few exceptions, over to CCH in the next couple of months. Happy to take any questions.
Questions? With that, thank you, gentlemen. We've also, unless anyone has anything else, we've exhausted the agenda and the meeting's adjourned. Thank you.
Thank you.